Good morning, everyone. Thanks for joining us, and thank you to Premier Health for arranging this and being here with us this morning. Taria was able to secure Dr. Allen to be with us this morning. Few housekeeping items before I turn the floor over to him. If you click your participants at the bottom, that'll allow you to see who's in the room. And then you can also click the chat. If you want to put your contact information into the chat, feel free to do so. We have a small enough group this morning. We will open it up kind of to the floor to ask questions after Dr. Allen has kind of given an update and stuff. So instead of us doing questions through the chat, what I'll just ask is that you kind of chime in, not interrupting people, and ask your questions. Dr. Allen, if you're okay with that after you kind of give an update.
That sounds great to me.
Perfect. All right. At this time, I'll go ahead and do a brief intro for you, Dr. Allen. Premier Health is an annual sponsor of the Beaver Creek Chamber, so we want to thank you guys for being a great partner of ours. Dr. Allen is board certified in family medicine and is a graduate of Wright State University School of Medicine. He completed his residency through the Dayton Community Family Practice Residency Program at Good Sam. Dr. Allen's special interests include pediatric health, sports medicine, prevention medicine, and he is also a team physician for Bethel Local School. Dr. Allen lives in Dayton with his wife and 2 children. Dr. Allen, the floor is yours.
Oh, well, thank you guys. Appreciate it. I'll also throw in there that we've been kind of part of the Beaver Creek community a little longer than I've even lived there. My wife's a teacher over at the middle school. She kind of worked both Ankeny and Coy, so I don't know if you guys may have come in contact with her as well, probably more than myself over there. But appreciate you guys having me. Really to kind of give you some updates on COVID-19. Really what I'll focus on is kind of the testing. That's really where I've come in and what I've been doing since this really started. So on, gosh, what was that, St. Patrick's Day or so of this year, we opened up our UD site, and I happened to be part of that. So we kind of have 2 different tests that we're running at the moment here in Dayton. We have a PCR test, which is looking for the RNA of the virus, so that genetic code of the virus there. We do that through the nasal swab. So the nasal swab that you hear about, where they stick that Q-tip way deep back in the back of your nose and get some sample from there, send it out, put it in a fancy blender, if you will, and some reagent, and run it through a little bit of a machine there that does some testing, and it'll tell us if the RNA is present. That is really used for those acute diseases. So if you think you have a fever, cough, you think you may have this currently, or your physician thinks you may have this currently, that's the test they're going to order and you're going to have done. The second test that we just started, which has been a little bit more kind of cutting edge for us here and really across the country, is doing these IgG tests, or the antibody test. Early on, there were a few folks who were doing antibody testing here in the area, mostly in Tip City and up north. Those antibody tests were what we call point-of-care testing, which means they would kind of stick your finger and take a little bit of blood and test it right then and there, and in 15 minutes give you an answer. What we found is those tests are pretty inaccurate as far as our testing standards. So as far as what we did at Premier, what we were using down at UD, is we decided not to go with those types of antibody testing. So we waited a little longer, and we went with what the Abbott company developed, which is a blood draw. So they take a significant amount of blood, much like if you had your cholesterol checked, or you were getting a CBC, or some other labs drawn for your normal yearly physical. They draw that blood, and then they send that off and do our special little magic to it. And what that's looking for is a protein in your blood that is an immune complex. This IgG is the long-term immune complex. So if you want to think about that, I relate it to chickenpox. It's probably the easiest way to think of it for us that are familiar with that. Chickenpox is a virus you get. Once you get it, you have an acute response that your immune system produces to fight it off, which is an IgM, or immunoglobulin M. That IgM response is quick. It comes on fast, and it leaves after about 2 weeks or so. This IgG hangs around on chickenpox anyway. It hangs around traditionally for your life. So you don't typically get chickenpox again. Now we can get shingles and all these other things, and there's other reasons for that. But you don't get chickenpox again because you have this protein that's hanging out there and will attack the virus as soon as it sees it. Kind of gives your immune system some memory, if you will. It says, hey, we've seen this before. We know how to fight this off, and let's take care of that. Well, that IgG, that long-term immunoglobulin, is what we're looking for with these COVID patients. And folks that are coming in, getting their blood draws, and we're looking for this antibody. Finding that antibody, we don't know exactly what that means just yet for the for folks with COVID. With other viruses, we can tell you exactly what it means. We know that it can produce long-term immunity. It's going to be key for us to develop an immunization later, is using this protein and really getting our body to start producing this protein without having the disease. That's traditional. We don't know that about COVID. We can extrapolate that information. We can say that we think that that's what's going to happen, but we just don't have enough data, enough time with this to understand that that's exactly what's going to occur here. I would say that it probably is. We probably are going to see that with this virus, but it's a crapshoot. The one thing that's been very interesting for me as a medical professional at this time is what I knew to be true yesterday about this changes tomorrow. So it's constantly updating and changing, and what we thought to be true is no longer true the next day, and really keeps you on your toes. And that's different for us in medicine. We typically we have a very good concept of what's going on or what a disease process is, and in this case we don't. So we're really kind of making it up on the fly a lot of times. But nonetheless, if this acts like other viruses, this IgG would be your long-term immunity, and what that tells us is that you were exposed to the virus. You produce the appropriate immune response, and you should have immunity to it for however long that protein hangs around. Most people, that would be for many decades. There are cases, as you may have heard, of chickenpox, that people get this when they're chickenpox when they're a kid, and then when they're 30, they get another case of it. In that situation, it's likely because the immune complex for some reason was either not being produced appropriately, or for some reason was the body adapted and did not produce it correctly later on in life. So nonetheless, with this thing here, that's really what we're checking for now. Currently in our what we're looking at is all the people we've tested, and we've run at UD, we've run approximately 6,000 tests, ballpark it. Those 6,000 tests, of those 6,000, about 4,500 or so have been the traditional nasal swab that we were talking about. Of those, about anywhere between 9 to 10% of them have been positive. So those are our patients that we think, they have symptoms consistent with this. We're worried that they look sick. They come in, they get tested. About 1 in 10 of them that we think look sick. What that tells us is that there are a lot of other viruses out there that can cause this. There are allergies. There are other things so everything that this thing produces as far as symptomology can be really had with other viruses as well. So we did run a lot of viral panels as well. So we tested for a lot of other viruses with that one swab. Those things were hit or miss. Early on, we saw a lot of flu positive folks. So folks that thought they had COVID, they had the flu, which makes sense. March, we see that. Here recently, we haven't seen much of the flu. There are some other viruses floating around, but we haven't been able to identify them on our limited testing that we do. But nonetheless, about 10% of those people who have come down to UD and been tested for this with acute symptoms have shown positive. The other piece of that is that IgG test that we've been doing. We're at 1,500 or so, probably a little more than that now on the updated numbers, but 1,500 as of maybe Monday morning. So 1,500 tests on the IgG, about 7.5 to 8% of folks that have been tested have been positive for that. So that tells you that two things. One is that it's maybe not as prevalent in our area as what we think it could be, which is maybe good. It also could tell us that we did things, even though Dr. DeWine has been very aggressive, maybe it was the right move, and it's kept people from getting infected. And we hear a lot of anecdotal stuff, and you guys certainly, I'm sure, as you've talked to folks around the community, you've heard this as well, that, man, I had this cough that just wouldn't go away in January. I was sick in December. I was sick in February, whatever it may be. And I swear I must have already had this. We hear that down there constantly, and when we test them, 7% of them come up positive for this. So they may have had another disease, or another virus. With the new reports that came out that said our first patient that had this presented possibly in January, as early as I think it was January 7th or something like that. That's a tough one to quantify. I know the news puts that out there. I know that there's a lot of information out there about that, but honestly, what they're doing there is this person tested positive, and they asked them when they had symptoms. And they said, well, I didn't have symptoms except in January. And so that's what they're saying, oh, it must have been this. It really could have been a lot of other things. What we've also seen with this disease is that with COVID, there's been a lot of folks that have this that have no symptoms. One of our Beaver Creek residents that I know very well. His wife was very sick with this and in the hospital, and he was exposed to her, obviously, and he tested positive, but he never had a symptom. He said he never even felt fatigue, never had a cough, never fever. She was obviously very sick. He didn't show anything. Both of them were positive. So I think there's probably some of that going around too, where folks didn't have any symptoms at all, and they may have been exposed to this. But honestly, it's a very interesting time in medicine. It's certainly a new for me. I was certainly not used to this, so it's been interesting. I can't say always fun, but certainly rewarding at times where you see these folks come through and you feel like you're doing some good work. So it's been a lot of fun to be involved with that testing. Certainly, I know there's probably a lot of other questions. I'll leave it up to you guys if you want to have some questions about things. I'll be happy to discuss anything else you have about this COVID stuff.
Thank you, Dr. Allen. I appreciate it. You guys, I'll go ahead and open the floor. Like I said, we have a small enough group, so if you'd like to unmute yourself and ask Dr. Allen any questions regarding any of this kind of as a whole, feel free to do so.
Yes, doctor. This is Brian.
Hey, Brian.
Hi. Got a question. This testing that Premier is doing at the UD site right now, is that antibody testing or is that your blood draw testing?
Yeah, so the antibody test is the blood draw, and we're doing the antibody testing there. So if you drive by there right now, you'll see 3 kind of big tents out in the parking lot. Those 3 big tents, one of them is a registration tent where we bring folks in and figure out where they need to go. One of them is a tent where they're doing those nasal swabs to test for the acute disease, and then the other tent is where they're doing the blood draws and doing the antibody testing. So we're doing both down at UD. That was designed just to kind of a little bit of background, like why UD Arena, or why did we decide to use that as our kind of base of operations, if you will. With this disease being so very, the infectivity of it was pretty high. We wanted to make sure that we had this out and away in an open air environment, somewhere away from our offices. We didn't want these folks that could be potentially positive for COVID coming into our offices and infecting other people that are high risk for this disease and bad outcomes. And it just happened that we had some partnerships with UD as we take care of their athletes there, and they had canceled their first 4, and I said, "Whoa, they've got this whole parking lot. Can we use the parking lot?" And it was pretty amazing. That whole thing was planned in about 12 hours. That's how we ended up there.
Okay, so yours is not the finger prick like Tip City did up there.
Correct. Yeah, the one at Tip City was a test that was Arc Point Labs, I believe was the name of the place up there doing that. That yes. Finger stick was found to be somewhere in the 65 to 70% sensitive and specific. And I know that those are terms that maybe if you're not reading up on a lot of testing, you wouldn't be familiar with. But the blood draw, to put that in kind of comparison, the blood draw is 100% specific and 99.5% sensitive. Which are pretty good numbers from labs, and that tells you how accurate a positive result is and how accurate a negative result is, if you want to think of it that way. So at a 70%, 3 out of every 10 that you test that are negative would be positive. And so a false negative is more dangerous to me than a false positive. If somebody tests positive and they're otherwise doing pretty well, I'm going to send them home, tell them to self-quarantine, keep pushing the fluids, monitor closely, and it's maybe not ideal, but nothing dangerous necessarily will happen. If they're falsely test negative, then that patient may think that, hey, I'm fine. I don't need to do anything, different. I'm going to go out to Kroger, or I'm going to go out and shop and be exposed to a lot of the population that could spread that disease. So we didn't feel real comfortable with the numbers there, so we waited for this newer test that kind of just tends to be a little bit more accurate for us.
I had a question.
Yeah.
If and there's a lot of speculations of stuff out there and stuff like that. How accurate are in your opinion, the actual death numbers, for COVID, and not just the rumors of a hospital makes more money when it's a COVID-related death, but along those lines of if there's any type of complication or any test whatsoever with COVID, are they automatically tracing that as a COVID death? And just what is the legitimacy of those conversations?
It's a great question. I think I can tell you so I can't speak for, hospital systems across the country. Everybody does their own thing and does it a little differently. I've heard the stories in New York of, some of that maybe abuse of those numbers, if you will. Here in our hospitals, being, certainly intimately involved with Miami Valley Hospital in particular, Atrium and Upper Valley, which are the 3 hospital systems in Premier, which I work with. They really are, if they don't have there are these presumed positives and these positive positives, if you want to think of it that way. The presumed positives, those are Ohio Department of Health. They kind of handle that. But for us in our hospital system, if the patient tests positive for COVID and subsequently, dies from something in there, then they would be reported as a COVID as related to death possibly. And the way that those death certificates work is it asks you for a primary cause and then anything else that may be related. So if they test positive for COVID, they're going to have that listed on their death certificate. How each state or how each kind of municipality chooses to report those is a little bit different. But here, if it's listed on there, they're probably going to get lumped into those numbers of COVID-related deaths or COVID deaths. Not always accurate. COVID may not be the thing that got them. I mean, I think of if I had a patient that had COVID but had a significantly bad COPD and was not doing so hot anyway, and this was the straw that broke the camel's back, if you will, then they would be counted as a COVID death, but it was the 40 years of smoking and everything else that got them. It wasn't really that. It just was the last straw, if you will. However, in some of the other numbers, to comment on like the bigger numbers, so, the death rate, for instance, you hear these big numbers in the death rate. Well, part of that is that we're just not testing enough folks. I would say that as we test more and we find that more people have had this disease, that denominator gets a whole lot larger and that death rate gets a little bit lower. So we have pretty good confidence. I would say I would feel fairly confident that the death rates reported in the state for COVID are just what we described. They had COVID for some reason and they happened to have a demise from whatever it may be. So those death rates are what they are. But the bottom number, but they're going on who had the disease, how many people have actually been diagnosed with it. Those numbers are going to go markedly higher as we look at who had this and our testing ramps up. So as our numbers on the denominator get much larger, our death rate's going to get a little bit lower as far as a percentage. So I think that those numbers are going to change dramatically. The scary numbers of, oh my gosh, you hear, I don't know, in Italy, you're hearing some stuff that was 7, 8, 9% of some of these folks. That's not going to be as high. I think we're going to see it more relatable to other viruses that we see. If it was 1%, that's still a pretty high rate. So maybe 1%, but maybe a little bit lower than that even.
Okay.
Other questions?
I'll go again if nobody else has another one.
I think Brian's got one.
Yeah, go ahead, Brian.
Yeah, just real quickly here. There are different types of masks, cloth and other things, not the N95s, but all the ones that we have access to. If we do choose to wear one of those, which is the best choice or the worst choice? That's
a good question. So if you choose to protect yourself and the folks around you, right, because the mask protects more than just you. For protection of folks around you, really anything is pretty good. It's going to, you're really trying to stop that droplet, that projection that we all see and droplet spread. And so it keeps it off surfaces, it keeps it off other people, keeps it from being aerosolized, and certainly breathing it in. So for protecting other people, anything that you use to cover your face is going to be at least helpful and be about as good as anything else at this point. For protecting you as far as bringing things back in and breathing in, the N95 mask seems to be the standard of care. It's what we use down at UD if we're doing those nasopharyngeal swabs. Now, I would say that is a high-risk procedure in the sense that if I stick this thing all the way back in your nose, you have a very high likelihood of having to cough or sneeze or have some other kind of reaction there, visceral reaction. They could spread droplets. So we use an N95 mask when we're doing that. However, when we're doing the blood draws and we're doing exposure to people as we're checking them in, we use a surgical mask. We don't use an N95. So the surgical masks are, if if used appropriately, and I mean appropriately by wearing them over your mouth and nose. We see far too many of them that are worn, on somebody's chin or worn below their nose, and those aren't going to help much. But if worn appropriately, if you have 2 patients in a room, I say 2 patients, if there's 2 people in a room within 6 feet of one another, both wearing surgical masks, and one of them is COVID positive, your rate of infection for the other person, even at 30 minutes in the room with them, is far less than like 0.5%. Which is not, that's still a pretty high number, but it's not great, but it's still way lower. So with a surgical mask, you're protected very well. And certainly that's why we ask everybody to wear some sort of face covering. If you can cut down on the droplet presentation, the droplet exposure, and then wear a surgical mask on top of that, you're going to protect yourself fine. So for you, if you're out and about in the community, really anything is good. A surgical mask is a step up. The N95 is probably a little bit overkill. Actually on Sunday morning, I ran down to Bill's Donuts, and there was a gentleman there that was wearing a full respirator mask, and this whole get up that is probably just a little bit too much. Is it going to protect him? Sure, but it's probably a little overkill. The other thing I'll speak to just from your mask question is gloves as well. I'm sure we've all seen the kind of different discussions about gloves out there, but they're okay if you're going to use them for something that you may touch and then remove the glove and get rid of it and what have you. I'll use some folks at UD as an example of this. We've had people that come into the testing center, come in to register, and they're wearing the gloves as they're driving in their car. They have a mask on. The mask is below their chin. The gloves they've been wearing for gosh knows how long. And on top of it, they've got a bag of fast food in the front seat that they're eating out of with the gloves on. And so it just defeats the purpose of having. Don't use them then. So so there's a little bit of debate about that. Really, the gloves are okay if you want to feel a little bit more protected, but don't use them for a long period of time. Once you touch a surface, you want to remove the gloves. The better process, in my opinion, is just wash your hands regularly. If you're using hand sanitizer, that's fine. But if you can wash them with soap and water, it's a little bit better.
Thank you.
Yeah, no problem, Brian.
I have a question. This is Marie.
Hey, Marie.
How are you this morning? And thanks for doing this, by the way.
Oh, no problem.
Okay, so both my husband and I are at risk age. I'm 63. He's in his 70s. And so we kind of limit the amount of time we spend away from the house as much as we can. But at some point, we have to go out. We can't cloister in the house forever. We would drive each other crazy. Yeah. What is, when we go out, we do wear masks and everything, but what do you think will be the right time for us to get out there without having to worry about it?
That's a great question. I tell you, I've thought a lot about that, and certainly between what I mentioned earlier, my wife's a teacher out there. She struggled with the schools closing, and she's certainly a social individual, so she wanted to be out and about, and she struggled with that. So we've had these conversations. When is it right? I think that the answer for everybody is really whenever you're comfortable with the risk. And I say that, I know it's kind of a hedging out of the question a little bit, but I'll use an example of I drive up and down 75 to get to work every day. My risk currently, and I know I'm not in the same risk category as yourself, but my risk currently, I am at much higher risk of being flattened by a semi on 75 than I am of getting COVID and passing away from that. So whenever we're comfortable as a society with that risk, because that risk is not going to go away. The virus is here. It's going to be here. It's likely not going to go away. Now, I will say that as it runs through the population, the first time it runs through the population in these with any of these virus models is that it's always going to be more dangerous the first time we see it. It's going to have a higher death rate, and things are going to go, much worse the first time. As we build up that immunity and we get that herd immunity going, then we'll be in a much better position, and the risk will be much lower. But it's really whenever we feel as a society, we feel comfortable with that as individuals, and honestly, I say that, use that 75 example, and I don't even think twice about it. I got to go to work. I jump on 75. But I think we're in the same boat. This is new for us to some extent, and I say new in the sense that we get these pandemics every 5 or 10 years. We see these new viruses. This one's a little bit different, but we see those constantly in the human race and across nature anyway. Our response to it has been markedly different, at least in my lifetime. You can go back to the 1918 Spanish flu and look at those and their reactions to it, but our reaction to it at this point has been markedly different. I know we're all a little bit hesitant. We're all a little bit risk averse for this at the moment, which is fine, and I think it has been appropriate. But as we get further along and we become more comfortable with the testing and the numbers of folks that have had this and recovered, we'll feel a little more confident about that. And really for the politicians, so for Dr. Acton, DeWine, those folks, as those numbers of the IgG testing go up, if we start seeing numbers, and I know, like I said, we're at 7.5%, 8% right now in Dayton, if we start seeing those numbers up around 30 or 40 or 50%, you have a much higher likelihood of being much more comfortable of opening everything up. That means half our population has been exposed to this. They've had the right immune response. But you're exactly right. It's really a personal decision of when you feel that the risk is acceptable for you. I think as we move forward with this, we'll become more comfortable with it. We'll, as a population, we'll start treating it more as we do like the flu. And I hate to say, oh, it's like the flu and get, I know there's a lot of differences, but we'll treat it more like that as we become more comfortable with it. It's just another virus that we deal with. But it's going to take a little time for it to run through the population. Once it has that first pass through the population, we'll be in a much better position. So sorry, I kind of hedged the answer a little bit, but I hope that helps you a bit.
It does. It helps a little bit. I mean, there's other issues at stake, but it's just, with everything starting to open up, the desire, I guess, to want to go out.
Oh yeah.
There even more.
Yeah, I could use a good restaurant meal here eventually, but
you and me both.
So I have a question. I came on about 5 minutes late, so I might have missed it. But how long does it take to get the results for the IgG
Oh,
test?
no, I didn't discuss that, so thank you for asking it. So as you guys may remember, when we initially started this testing, there was an overwhelming amount of testing that was being done across the country. There was a lot of testing obviously being done here as well, but we didn't have a whole lot of bandwidth here in our local labs to run these tests. So we were taking a lot of these tests, collecting them, and sending them out to our national labs that could run this. A couple of those national labs, one was located out near California, another one was out near Washington, D.C. And so when we initially started running these tests for the swabs, we were having time delays of 8 to 10 days on some of them, and that really was because California got hit at the same time and flooded the lab. New York got hammered at the same time, they flooded the lab, and we got pushed on the back burner. So we developed our own we bought the machines that we could run these tests and run quite a bit more of them here in-house, which sped up our time. So now if you have a nasopharyngeal swab, the turnaround on that currently, we quote 2 to 3 business days or 2 to 3 days on that, but I'll tell you, it's coming back within 12 to 24 hours in most cases. The IgG or the antibody test, it's very similar. We quote a 2 to 3 day turnaround, but we're really getting back much quicker than that. So you can expect if you go out to UD and you get tested that you'd probably have your results either if it's in the morning, you potentially could see them that evening, but generally by the next morning you'll have them in your in basket.
Okay, one more
Michelle,
question.
Yeah.
Oh, sorry.
Go ahead, Judy.
Okay, thanks. So for the contact tracing, are they doing it for both tests or just the swabs?
Yeah, they're doing it for both. So the Ohio Department of Health, if wants to be notified of all of our positives, whether they're antibody or the acute PCR test, the part of the questionnaire, if you happen to go on CompuNest's website and fill out the questionnaire there, or if you come down to UD and decide to have this done, they give you a little registration form with some questions on it. And one of those questions they ask you is that, hey, we're going to divulge this to our Department of Health. You have to kind of initial saying it's okay to do that. We're not able to run that test here in Ohio if the patient doesn't agree to that. So part of what that information is going to be used for is tracing, just like you said. So that's how they've kind of gotten back to those patients that may have had this early on. They tested some, they found some antibodies, they went back and said, hey, when were you sick? They said, oh, I was sick in January. And so then that's how they said, oh, well, our first case may have been in January here. Like I said, I don't know if I buy that completely, but at the same time, they are using it for tracing.
I've got a question.
Yeah.
This is Michelle. So this, again, I got on a little bit late because I was trying to get into the meeting that was for next week. So apologize if this is something that's repetitive or it might be a little bit off subject, but I have a child and I'm a little bit worried about what they're talking about, this new inflammatory syndrome that's going on with children in New York. And it could be linked to the COVID. Do you have any information on that?
So really not a whole lot more than what you may have read already or seen on the news. It looks like there might be some tie to this. I think that's not unreasonable to think that there is some manifestation in children. Generally speaking, our younger population is pretty immune to this. If they get it, they don't have much of a hiccup. They barely notice it in most cases. However, it does look like it could be related to this inflammatory response. Now, what I'll say is that that's not unprecedented in viruses. If you think about the flu, we have something called Guillain-Barré that's associated with the flu. A handful of kids here in Dayton get that every year, and it can be deadly. Generally, we treat it very well. What happens is that the flu affects the nerves. It doesn't cause a rash or anything else. It just affects the neurologic system and from the feet, and it starts moving up the body where it starts to induce a temporary paralysis that can last weeks, and it can be permanent in some cases, but lasts weeks to even sometimes a month. And if it gets high enough up into where the nerves that control the diaphragm, the child would stop breathing. And if they don't have ventilator support at that time, they would, obviously expire. So it's not unprecedented to think that viruses affect children in different ways or cause secondary issues. So I think that there's probably some legitimacy to that. As far as the rate of which that happens, it's a pretty small rate, but it's still somewhat risky. I think that if I had a child and they started showing a funny rash, I would probably take them in and be evaluated pretty quickly at this point. But understanding that 99.999, however many percent of rashes we see in kids are not this. But it is a little scary if you have children. I have two of my own that if I saw this, I'd be a little bit concerned. But at the same time, it's not unprecedented that other viruses do this as well.
Thank you very much.
Yeah, no problem.
Well, Doc, you're still there. I don't have a question, but I have sat through many Zoom meetings on this subject, and I just want to say this is probably one of the most refreshing and balanced presentations I've heard. So thank you.
Thank you, Bo. I appreciate that.
Thank you, Mayor. Joe, how many people are you testing daily?
So it was pretty funny. The first couple days or first couple weeks, we were just doing the nasal swab, and we were doing about 300 to 350 a day through there. And then it started to die off a bit. The next few weeks was about 200 a day. Then it was down to 150 a day for a few weeks. And by 2 weeks ago, we were only seeing about 70 a day. I mean, it was almost like clockwork, 70, 72, 70, 72, almost every day down there going through just the nasopharyngeal swab. When we opened up the antibody testing last Monday, for whatever reason, you would expect the antibody testing would garner some interest. So we had a lot of folks come down for that, about 220, 230 or so. But we also had an uptick in our nasopharyngeal swabs. So we're seeing 120 or so of those a day now. So up from 70 the week before. So on Monday of this week, we saw 264 antibody tests through, and we saw 123 nasal swabs. So we're back up to about that 350 mark. And what we do down there and how we do it, pretty confident we can handle probably upwards of 500 a day if we needed to. But yeah, we're seeing about 350 a day now.
So you guys have more capacity if that would be the need.
Yeah, we've been through, as you can imagine, when you develop something like this so quickly. Like I said, we came through in 12 hours and got it up and running, and then made many adjustments on the fly as we went through and discovered we needed to do some things differently or be more efficient. In our last iteration here, with adding a kind of a third tent and splitting out our registration process, we've become much more efficient. If you would have, that first day we did the antibody testing, even though it was pretty busy, it was only 330 cars that came through. We were not very efficient. We had to try to learn what we were doing and figure out our mistakes. And by Tuesday, we were much better, but we were very slow on that Monday. Now your throughput's within, if you come in from antibody test, 15 minutes, maybe 20 tops. By the time you pull in, get registered, go get your blood drawn, and on your way out. If you're there for a nasopharyngeal swab, it's even less than that. It's about a 4 to 5 minute process. So we can run them through pretty quickly and certainly have more capacity.
That's great. Thank you.
Yeah, absolutely.
I have another question if there's no one else going to pop in for another something. So obviously, business-driven organization. Is there any recommendations you have for businesses as they start to open up? Obviously, the cleaning processes, but from like your side as a doctor, do you have other recommendations for businesses?
Yeah, I'll tell you, it's tough. I know we've certainly to some extent, and I know I'm not a business owner like you guys, I'm an employed physician through Premier, so it's a little different, but we still have those same concerns of patients coming in, much like customers would come in. And some of my friends that do own their own businesses, you talk to them, and it's a tough one because you're kind of stuck in this quagmire of not only do you want to feel safe, but you want to make sure that any of your customers or anybody that's coming in to visit you feel safe as well. I think that we talked a little bit about the masks earlier. I think that's a great thing to use and help people feel safe. If you're in a service-oriented industry where you have to go out and be in people's homes, that does open up a whole different can of worms. But I think that's still needed. And you just want to make sure that you probably, I think the best advice I would have is make sure that you're touching base with those customers or whomever you're interacting with and make sure they're comfortable with whatever you're doing. At the same point, you want to be comfortable, but you want to make sure that if you feel comfortable in a cloth mask, if you talk to them, they say, oh, I'd really prefer a surgical mask, that you're able to adapt for that if you can. And I know that that's not always possible, but I think asking them and getting their idea of what they're comfortable with is a good thing. We all know what the CDC recommendations are at this point of, wear a mask, stay 6 feet apart, all that social distancing and all that, which is all fine and dandy, but you still have to run a business. And so at this point, if anything you can do to help protect, that's good. If you can have your customers, or in my case, my patients, feel more comfortable with the situation, that's going to help you. And then certainly you always have to make sure you feel comfortable with the situation as well. But it's going to be a tough one. I think as we discussed earlier, when's the right time to open up or when's the right time to go back out? That's a different answer for everybody. And I don't think there's a real cut and dry answer to that. But for the businesses here, certainly I think that's the biggest piece, is just make sure the community is comfortable with what you're doing and ask those questions. I don't think it hurts to get that feedback. And we certainly did it with our patients in here. And we got some good answers back that helped us garner what we do in the office here and how we handle patients. One of which was we didn't want people in the waiting room all that long, so we're trying to get them back a little quicker. But we also offered them the option that when they came to the front door, that if they felt like they didn't want to sit in the waiting room and it was going to be 5 or 10 minutes, that we asked them just to go to their car and we'd call them on their cell phone. In some instances, if they had symptoms consistent with COVID when we first started here, we were seeing them in their car. We'd have them pull around the back and we'd go out and take care of them out there. So adapting to what you need to do for your customers would be probably paramount. And you guys, if you run a successful business, you already know that. I don't need to hammer that to death.
No, I think it's a good piece of advice. So thank you. Other questions? All right, I don't see anything else. I don't see anyone unmuting themselves to prime in to get a question asked or anything. So
it's a good sign, I guess.
I think it was all good information for everyone and for our businesses. So we really do appreciate you taking the time, Tria, for setting this up. I know that time is extremely valuable these days for you guys. So we really do appreciate you coming on and answering the questions for everyone. So those of you who are in attendance, thanks for joining us. We do invite you to join us next Thursday on the 21st at 9 a.m. We will have Melissa Howell back, Greene County Commissioner of Greene County Public Health, and she will be providing kind of her second update for us for area businesses and stuff as we're opening back up. So if there is nothing else at this time, we wish you guys a great day. I think the sun is trying to come out there, so we'll see. But again, Dr. Allen, thank you so very much.
No, I appreciate it, guys. Anytime that I can be helpful or if you need any input from me, I'm happy to do it. So thank you for having me on.